Azathioprine A has several drug-drug interactions that are clinically significant due to its metabolism and immunosuppressive effects. Here are the main interactions. 1. Allopurinol, febuxostat, and oxypurinol, xanthine oxidase inhibitors. Effect: severe toxicity, myelosuppression, pancytopenia. Mechanism: xanthine oxidase metabolizes azathioprine into inactive metabolites. Inhibitors increase azathiopриne's active metabolites. Recommendation: avoid combination if possible. If used, reduce azathioprine dose by 75%, 90%, and monitor closely. 2. Aminosalicylates, e.g., mesalamine, sulfasalazine, olsalazine. Effect: increased risk of bone marrow suppression. Mechanism: inhibit thiopurine methyltransferase, TPMT, leading to higher active metabolite levels. Recommendation: monitor for myelosuppression, e.g., CBC regularly. 3. ACE inhibitors and angiotensin II receptor blockers, ARC. Effect: increased risk of anemia and leukopenia. Mechanism: additive myelosuppressive effects. Recommendation: monitor CBC during concurrent use. PA4, warfarin. Effect: reduced anticoagulant effect of warfarin. Mechanism: unknown. Recommendation: adjust warfarin dose and monitor INR closely. 5. Live vaccines. Effect: increased risk of vaccine-induced infections. Mechanism: immunosuppression reduces vaccine efficacy and safety. Recommendation: avoid live vaccines, e.g., MMR, yellow fever in patients on azathioprine. 6. Ribavirin. Effect: increased risk of myelosuppression. Mechanism: ribavirin inhibits inosine monophosphate dehydrogenase, affecting azathioprine metabolism. Recommendation: avoid concurrent use or monitor closely for hematologic toxicity. 7. Other immunosuppressants, e.g., cyclosporin, tacrolimus, biologics. Effect: increased risk of infections and malignancy. Mechanism: additive immunosuppressive effects. Recommendation: use cautiously and monitor for infections. 8. Cotrimoxazole, trimethoprim sulfamethoxazole. Effect: increased risk of bone marrow suppression. Mechanism: additive hematologic effects. Recommendation: monitor CBC closely or consider alternative prophylaxis. 9. Nonsteroidal anti-inflammatory drugs, NSA. Effect: potential for renal toxicity and exacerbation of myelosuppression. Mechanism: additive effects. Recommendation: use cautiously and monitor renal function and CBC. 10. Other myelosuppressive agents. Effect: increased risk of bone marrow suppression. Examples: methotrexate, cyclophosphamide, chlorambucil. Recommendation: monitor hematologic parameters closely. General recommendations for patients on azathioprine: regular CBC and liver function tests. Test for TPMT activity before initiation to assess risk of toxicity. Educate patients about signs of toxicity, e.g., fatigue, infections, bleeding. Would you like more details about a specific interaction? Azathioprine and xanthine oxidase inhibitors interaction. Key xanthine oxidase inhibitors: allopurinol, febuxostat, oxypurinol, active metabolite of allopurinol. Mechanism of interaction: azathioprine is metabolized into 6-mercaptopurine, 6-MP, which is further broken down by various enzymes, including xanthine oxidase XO. Xanthine oxidase inhibitors, e.g., allopurinol, febuxostat, reduce the activity of this enzyme, leading to accumulation of 6-thioguanine nucleotides, 6-TGNs, the active metabolites responsible for azathiopриne's immunosuppressive effects. This increases the risk of severe myelotoxicity, including leukopenia, thrombocytopenia, anemia, and pancytopenia. Clinical consequences: 1. Severe bone marrow suppression. 2. Life-threatening infections. 3. Other toxicities, e.g., gastrointestinal disturbances, hepatotoxicity. Management of the interaction. 1. Avoid the combination if possible. Whenever feasible, use alternative urate-lowering therapies that do not inhibit xanthine oxidase, e.g., probenecid. 2. If combination is necessary, allopurinol, reduce the azathioprine dose to 25 to 33% of the original dose, i.e., decrease by 67 to 75%. Example: if the original dose is 100 milligrams per day, reduce to 25 to 33 milligrams per day. Febuxostat. Avoid concomitant use, as febuxostat causes a more profound inhibition of xanthine oxidase than allopurinol. If unavoidable, use extreme caution with close monitoring. 3. Monitor closely. Perform frequent CBCs to monitor for leukopenia or other cytopenias. Assess liver function tests regularly. Monitor for clinical signs of myelosuppression, e.g., fatigue, infections, bleeding. 4. Educate the patient. Advise patients to report symptoms of bone marrow suppression promptly, e.g., fever, sore throat, unusual bruising. Would you like further clarification or details on dose adjustments? Dose adjustment for azathioprine when used with xanthine oxidase inhibitors. 1. Allopurinol. Reduction in azathioprine dose. Reduce azathioprine dose to 25 to 33% of the original dose. Example, if the patient was on 100 mg per day, reduce to 25 to 33 mg per day. If on 50 mg per day, reduce to 12.5 to 16.5 mg per day. Monitoring. Start with the reduced dose and monitor CBC every 1 to 2 weeks initially. Adjust further based on blood counts and clinical response. Ta2, febuxostat. Recommendation. Co-administration is generally not recommended due to a stronger inhibition of xanthine oxidase compared to allopurinol. If unavoidable, use the lowest possible azathioprine dose, Ta 10% of the original dose. Monitor extremely closely for signs of myelosuppression. 3. Oxypurinol, active metabolite of allopurinol. Treat similar to allopurinol and reduce azathioprine dose by 75%. Monitoring plan. 1. Baseline testing. Complete blood count, CBC, liver function tests, LFTs, and renal function. 2. During treatment, CBC every 1-2 weeks for the first 6 to 8 weeks after dose adjustment. Monitor for leukopenia, thrombocytopenia, or anemia. LFTs every 2 to 4 weeks initially, then periodically. 3. Long-term. Monthly CBC and LFTs once the dose and blood counts stabilize. Key points to discuss with the patient. Importance of regular lab monitoring. Symptoms to watch for: infections, fever, sore throat or unusual fatigue, bleeding, bruising, unexplained bruises, petechiae or bleeding gums. GI symptoms: severe nausea or abdominal pain. Would you like to discuss alternative gout treatments to avoid this interaction? Alternative treatments for gout to avoid azathioprine xanthine oxidase inhibitor interaction. If azathioprine is essential for a patient, the following strategies can help manage gout without using xanthine oxidase inhibitors, allopurinol or febuxostat. 1. Uricosuric agents. Drugs that increase the renal excretion of uric acid. Probenecid promotes uric acid excretion by inhibiting its reabsorption in the renal tubules. Suitable for patients with normal renal function and no history of kidney stones. Dose: start at 250 milligrams twice daily, gradually increase to a maximum of 2 grams per day as needed. Monitoring: monitor uric acid levels and kidney function periodically. Ensure adequate hydration to prevent uric acid stones. HAP2, pegloticase, a recombinant uricase enzyme that converts uric acid to allantoin, highly soluble and excreted in urine. Indicated for severe refractory gout or tophaceous gout, administered intravenously every 2 weeks. Cautions: avoid in patients with glucose 6-phosphate dehydrogenase, G6PD deficiency. Risk of infusion reactions and anaphylaxis. Premedication may be required. 3. Lifestyle and dietary modifications. Effective in reducing serum uric acid levels and gout flares. Dietary restrictions. Avoid purine-rich foods, e.g., red meat, organ meats, shellfish. Limit alcohol, especially beer and spirits, and fructose-sweetened beverages. Hydration. Maintain good hydration to dilute uric acid and prevent crystal formation. Weight management. Losing weight can lower uric acid levels. 4. Non-pharmacological therapies for acute gout. Use NSAIDs, e.g., naproxen, indomethacin, colchicine, or corticosteroids for managing flares. Avoid aspirin as it can alter uric acid levels unfavorably. PAFRI5, non-xanthine oxidase-based uric acid synthesis inhibitor, under investigation. Emerging drugs such as lesinurad, a selective urate transporter 1 URAT1 inhibitor, may be alternatives, though availability may vary. Would you like a comparison between these alternatives or specific dosing details? Azathioprine and ACE inhibitors, ACE-I or ARBs interaction. Key examples of ACE-I and ARBs. ACE inhibitors: enalapril, lisinopril, ramipril, captopril. ARBs, losartan, valsartan, irbesartan, telmisartan. Mechanism of interaction. 1. Additive myelosuppression. Both azathioprine and ACE-ARBs can suppress bone marrow function, increasing the risk of leukopenia, anemia, and thrombocytopenia. ACE-I specifically can inhibit erythropoietin production, compounding the risk of anemia. 2. Hyperkalemia. Both drugs can increase serum potassium levels, azathioprine indirectly through renal effects, ACE-ARBs by reducing aldosterone. Clinical consequences. Cytopenias, increased risk of leukopenia, thrombocytopenia, or anemia. Infections, higher susceptibility to infections due to leukopenia. Hyperkalemia, risk of life-threatening cardiac arrhythmias. Nephrotoxicity, potential worsening of renal function due to hyperkalemia and nephrotoxic effects. Management of the interaction. 1. Avoid combination if possible, especially in patients with pre-existing risk factors for cytopenias, e.g. low baseline WBC or hyperkalemia, e.g. chronic kidney disease. 2. If combination is necessary, monitor hematologic parameters. Regular CBC every 1 to 2 weeks initially, then monthly. Watch for signs of leukopenia, anemia, or thrombocytopenia. Monitor electrolytes and renal function. Check serum potassium, creatinine, and eGFR regularly. Adjust doses of ACE-ARB or discontinue if hyperkalemia develops. Start at lower doses. Use the lowest effective dose of ACE or ARB to minimize risks. Patient counseling. Educate patients about the symptoms of myelosuppression, e.g. fatigue, fever, infections, and hyperkalemia, e.g. muscle weakness, palpitations. Emphasize the importance of follow-up for lab tests. Alternative approaches. 1. Switch antihypertensive therapy. Consider using calcium channel blockers, e.g. amlodipine, or beta blockers instead of ACE-ARBs if clinically appropriate. 2. Dose adjustment of azathioprine. No specific dose reduction is required for azathioprine with ACE-ARBs, but monitoring should guide adjustments if cytopenias occur. Would you like further details on monitoring protocols or alternative drug options? Monitoring protocols and alternative options for azathioprine with ACE-ARBs. 1. Monitoring protocols. Hematologic monitoring, CBC. Baseline testing. Complete blood count, CBC, before initiating combination therapy. During treatment, weekly to biweekly CBC for the first 4 to 6 weeks. Monthly CBC thereafter if stable. Red flags, leukopenia, WBC 4,000 mmHg, anemia, HB 10 grams per deciliter, thrombocytopenia, platelets 150,000 per millimeters coherent. Electrolyte and renal monitoring, serum potassium and creatinine. Check at baseline and within 1 week of initiating therapy or after dose adjustments. Reassess every 2 to 4 weeks initially, then every 1 to 3 months. Hyperkalemia threshold, potassium 5.5 milliliter requires intervention, e.g. reducing ACE-ARB dose or dietary changes. Clinical monitoring. Monitor for signs of infection, e.g. fever, sore throat. Monitor for hyperkalemia symptoms, e.g. palpitations, muscle weakness. Renal function decline, reduced urine output or elevated creatinine. 2. Management strategies for adverse effects. If myelosuppression develops, e.g. leukopenia anemia, reduce azathioprine dose. Consider halving the dose, e.g. 100 milligrams, 50 milligrams. Temporarily discontinue azathioprine if WBC drops significantly or if infection develops. Reevaluate ACE-ARB use. Discontinue or switch to alternatives if necessary. If hyperkalemia develops, e.g. K plus 5.5 millimoles per liter, implement dietary potassium restrictions. Consider diuretics, e.g. furosemide, to enhance potassium excretion. Discontinue ACE-ARB if hyperkalemia persists. Alternative antihypertensive options. If ACE-ARB interaction becomes problematic, consider switching to calcium channel blockers, CCBs. Examples: amlodipine, nifedipine, diltiazem. Advantages: no significant effect on potassium or bone marrow. Effective for hypertension and vasodilation. Beta blockers. Examples: metoprolol, bisoprolol, atenolol. Advantages: useful for hypertension and cardiovascular protection. Minimal interaction with azathioprine. Diuretics. Examples: hydrochlorothiazide, indapamide. Advantages: can help manage hypertension and reduce hyperkalemia risk. Caution: avoid potassium-sparing diuretics like spironolactone. Direct vasodilators. Example, hydralazine. Use case, alternative for resistant hypertension but less commonly used. Would you like detailed information about any specific antihypertensive medication or further advice on managing side effects? Azathioprine interactions with other disease-modifying anti-rheumatic drugs. Azathioprine, ZA, is often used in combination with other DMARDs for autoimmune and rheumatic diseases. However, its interaction with some DMARDs requires careful consideration to avoid adverse effects or toxicity. 1. MTX. Interaction. Both drugs are myelosuppressive, increasing the risk of bone marrow suppression, e.g., leukopenia, anemia, thrombocytopenia. Recommendation: monitor CBC closely. Use lower doses of azathioprine if combined with methotrexate. Sh2. Leflunomide. Interaction. Combined use significantly increases the risk of hepatotoxicity and myelosuppression. Recommendation: avoid routine combination unless strictly necessary. Monitor CBC and liver function tests regularly. 3. Sulfasalazine. Interaction. Both drugs may cause additive bone marrow suppression. Recommendation: monitor CBC regularly to detect early signs of cytopenias. Consider dose adjustments if myelosuppression occurs. 4. Hydroxychloroquine, HCQ. Interaction. No significant pharmacokinetic interaction, but HCQ may potentiate azathiopриne's immunosuppressive effect. Recommendation: generally safe to combine, but monitor for infections and hematologic changes. SOT5. Mycophenolate mofetil. Interaction. Additive immunosuppressive effects increase the risk of infections and myelosuppression. Recommendation: avoid combining unless required for specific conditions, e.g., severe lupus nephritis. Monitor CBC and infection symptoms closely. 6. Cyclosporin, CA, or tacrolimus. Interaction. Additive immunosuppression increases the risk of infections and malignancy. Cyclosporin may interfere with azathioprine metabolism, enhancing toxicity. Recommendation: avoid combination unless necessary, e.g., organ transplantation. Monitor for nephrotoxicity, infections, and myelosuppression. 7. Cyclophosphamide. Interaction. High risk of severe bone marrow suppression due to additive toxicity. Recommendation: avoid concurrent use unless absolutely necessary, e.g., for severe autoimmune diseases. Monitor CBC and adjust doses if used together. 8. Biologic DMARDs, e.g. anti-TNF agents, rituximab, abatacept, tocilizumab. Interaction. Combined use increases the risk of infections and malignancies due to overlapping immunosuppressive effects. Recommendation: use cautiously, particularly in patients with a history of serious infections. Monitor for infections and other signs of immunosuppression. 9. Tofacitinib and other JAK inhibitors. Interaction. Additive immunosuppression increases infection risk, e.g., tuberculosis, opportunistic infections. Recommendation: avoid combining unless benefits outweigh risks. Screen for latent infections and monitor closely. Monitoring plan for azathioprine with other DMARDs. Baseline tests: CBC, LFTs, renal function, infection screening, e.g. TB, hepatitis B, C. 2. Follow-up tests: CBC and LFTs every 2 to 4 weeks initially, then every 1 to 3 months. Monitor for infections and drug-specific toxicities. Would you like further details on a specific drug combination or management protocol?